Hello and welcome to tonight's BSP webinar, Time to Take Periodontitis Seriously, Economic and Societal Costs and How to Implement the Steps of Care in Real-World NHS Practice, Part 1. My name is Arianelle and I will be your host this evening. I'm a clinical academic based at the University of Birmingham, so I know tonight's speaker very well, and it gives me great pleasure to introduce a man who needs no introduction. I'm sure you'll join me in welcoming Prof. Iain Chapple. Iain is a Professor of Periodontology, former head of the Birmingham School of Dentistry, and the current Director of Research for the Institute of Clinical Science. Iain leads the Birmingham Periodontal Research Group, and outside of the University of Birmingham, Prof. Chapple has served the IADR Periodontal Research Group as President, Group Chair, and Councillor. He served the European Federation of Periodontology as Treasurer, Workshop Co-Chair, Foundation Chair of the EFP Scientific Advisory Committee, Editor of the JCP Digest, and EFP Secretary General. He was also British Society of Periodontology President in 2014 to 2015 and awarded various accolades over the years, including the Charles Tomes Medal of the Royal College of Surgeons, the IADR PRG Rizzo Research Award, the IADR Distinguished Scientist in Perio Research 2018, and also a Special Citation Award of the American Academy of Periodontology. Prof. Chapple is former scientific editor of several journals, including the British Dental Journal, the Journal of Periodontal Research, and current associate editor of the Journal of Clinical Periodontology and Periodontology 2000. He has written 10 textbooks and 29 book chapters and has published over 200 peer-reviewed manuscripts in the international scientific literature. And this year, Iain was recognised in the Queen's Honours List, where he was awarded an MBE for his services to oral and dental health. On behalf of the BSP, I'd like to take this opportunity to thank you, the audience, for joining us this evening, and for Prof. Chapple for giving up his time to speak with us. As a reminder, tonight's webinar will last approximately 1 hour, followed by an opportunity for questions. So please feel free to submit your questions in the usual way, and I will collate these and present them to the speaker at the end of tonight's talk. Finally, before handing over to our esteemed speaker, I would just like to draw your attention to the next webinar titled Avoidance of Doubt, the S3 Guidelines and Phased Treatment Approach to Periodontal Care within the NHS Dental Contract. And this will be hosted on February the 10th. And if you haven't already signed up, there's still time to do so. And I have been informed that the webinar will be free for all those who wish to attend. So I look forward to seeing you there. Without further ado, I welcome Professor Iain Chapple.
Thank you very much, Zira. It's amazing when a member of staff is working in your department, how you can pay them to make up what appears to be a very busy life. Anyhow, it's a great pleasure to be speaking to you this evening on the title, as announced by Zira. And I've decided to divide the presentation up into 3 sections. I'm going to start off by talking about the recent white paper by the Economist Intelligence Unit on the economic and societal costs of perio. Then I'm going to move into just present you with some new data from a few months ago on the BSP implementation of the new classification system. And then I'm going to finish off with a few brief slides on the S3 treatment guidelines that will move into looking at the British Standards Authorities, the BSA's new phased care system for managing periodontal disease in general dental practice and NHS practice, which, provided we stick to the rules, I think provides a far better financial remuneration. And then in the next webinar that Zira's just mentioned, Shazad Salim is going to take over from where I stop, if you like, and he's going to provide a lot of detail on how you implement that BSA system using the S3 guidelines. So hopefully it'll flow and run together. So this piece of work was an absolute pleasure to be involved in, I must be honest. It was an independent piece of work that was commissioned by the EFP and supported financially by Procter & Gamble, but it was done completely independently by the Economist Intelligence Unit. And the aim really was for them to provide us with an independent expert report on the global cost of perio. Instead, what they did with our agreement was to look at Europe and 6 countries in Europe where there was really robust health economic data from those national providers in those countries that the Economist could get hold of to do their modelling. And the reason that we did this was because, as you know, periodontitis is the sixth most prevalent condition of humans. Globally, it affects nearly 750 million people. And so you can see it is actually more prevalent than cardiovascular diseases and respiratory infections. But more importantly, it has a huge impact on society and on individuals, being responsible for more years lost to disability than any other human disease. Of the 354 human conditions that were assessed by the 2017 Global Burden of Diseases study, it's a threat to general health because of its association with various non-communicable diseases. And it's also the third most costly at 90 billion per year, not far behind diabetes and cardiovascular disease. But it's also a social disease. I call it the canary in the mine because it basically has a very, very high prevalence that's clustered in certain socioeconomically deprived groups. So it's a very, very good barometer of social inequalities. So when you look at what's happened to the prevalence of periodontitis in the 6 major countries that we looked at here, France, Germany, UK, Spain, Netherlands, and Italy, not a lot has changed between 1990 and 2010 in those 20 years, with the exception perhaps of Italy, where there is a slightly more acute decline, which I'll come on to later. So the process that the Economist team went through was they first of all conducted their own literature search. And then we provided them with, if you like, supplementary evidence that was missing that we felt was key. They then convened an expert panel to drive the dialogue and to understand more about the disease process and about policies. And we created a clinical pathway to enable them to do the modelling, which I'll show you in a moment. Phase 3 was then the quantitative analysis to assess the effects, but the health and indirect costs, of periodontitis in each of the countries studied. And then finally, they wrote the white paper up and published it in July of last year. So when we look at the analysis, the major outcome of interest was really looking at return on investment for different ways of managing periodontal diseases. Now, cost effectiveness, cost effectiveness is a way to sort of look at the cost of a particular intervention and to balance that against the benefit in terms of the tangible health outcomes. And that's something that they looked at. It also helps you, when you do cost-effective analyses, capture, if you like, the scale of the problem. So you can get an idea of the cumulative or aggregate burden of illness on society, and also the value of the different interventions, evidence-based interventions that you're modelling. I've mentioned the 6 countries that were looked at and explained why, because the data was available in those countries. And then the primary objective, as I mentioned at the start of this slide, was really to look at return on investment of different forms of periodontal management. Now, this is the care pathway that we developed, and that will be fairly obvious, I think, to everybody on this webinar that, you know, you can start off with health and then you can develop gingivitis. Gingivitis is reversible, so health can return, hence a double directional arrow there. But once gingivitis progresses to undiagnosed periodontitis, then that disease hopefully will be diagnosed. And then following the extraction of unsavable teeth, you would move into the different steps of care that you're aware of, step 1, 2, 3, and 4 being the stabilized periodontitis patient in supportive care or maintenance. And so you've got 2 major intervention points. You've got the intervention point on the left of the screen as you look at it, which is what we call a prevention intervention point, where you either keep people healthy or you treat the gingivitis to restore health. And then you've got the treatment intervention point for periodontitis, which is the top red arrow there. I'm afraid my mouse isn't working, so I can't wave it around the screen for you. but hopefully you get the point. And then the costs were modelled in different ways. There are what we call direct costs, which is what it costs to treat the disease. There are the indirect costs, which are things like the cost of time away from work, for example. And then there are what are called intangible costs. And those intangible costs are things like the impact on your quality of life and your well-being. And expert groups like the Economist have ways of modelling this and assigning a price to it, just as they can assign a price to quality life years, if you like. They can do that, so it helps with the overall financial modelling. And we essentially looked at 5 scenarios. The baseline or control scenario was what's called business as usual. In other words, carrying on in each of those countries, managing the disease the way we are at the moment. The second one was a negative scenario, and that was reducing the management of gingivitis to 10%. The third one was eliminating gingivitis entirely, so it's a very extreme scenario, just to stretch the envelope and see what the scope of difference was. Scenario 4 is not treating any periodontitis at all, so another extreme scenario. And then scenario 5 is diagnosing and treating 90% of periodontitis. And these were modelled over a 10-year period. I think it's probably important to point out that this was done for stage 2 periodontitis. We couldn't do it for all stages. It would have been an impossible model. So this is for moderate disease, and therefore, if anything, it's quite likely to underestimate the true costs for stage 3 disease and stage 4 disease. So there was an estimate of total healthy life years gained, and as I said, there is a price that can be assigned to each healthy life year. Then there was the total cost in euros, then the cost per healthy life year gained, then what's called an incremental cost effectiveness ratio, and then finally the return on investment. And the return on investment, as I'll explain later, is essentially for every pound or euro that you spend on each of those scenarios, those management scenarios, what kind of, how many pounds are returned, if you like, into the economy as a result, through people being back at work and feeling more positive, improved quality of life, etc. So this is the baseline cost of managing periodontal disease in these countries, and you'll see it's incredibly variable. You'll see it's huge in Italy at 97 billion, and that is essentially because healthcare in Italy, dental health, oral health care, is private only, and it's very, very expensive. The UK is not much better, but we have a split model where you have out-of-pocket expenses from the patient, but you have a significant amount being paid for by the state. And then the cheapest scenario there really is in France and in the Netherlands. And in France, they also have some contribution from the patient as well. If we then look at what happens in the scenario where you eliminate gingivitis through professional education of patients and then largely home care, as you can imagine, that's a relatively cheap way of managing patients. And so you can see that the costs come down really quite significantly, roughly by about 50% in some cases and about 30% in others. So there's a decent cost reduction through scenario 3. If we then look at the most expensive scenario, which was scenario 5, this is diagnosing and managing 90% of periodontitis. The cost of treatment is obviously huge. And you can see we get a massive increase in cost here, at least 4-fold. And if you look at Italy, you're up to 387 billion across that 10-year period. So what was interesting was to look at the return on investment. And what this bar chart shows you is for each country, there are 2 bars. The left-hand bar, so if you look at France at 40.4, that shows you that for every, this is scenario 3, I should point out, on the left. And then the one on the right for each country is scenario 5, diagnosing and treating 90% of periodontitis. But for eliminating gingivitis as an extreme scenario, you can see that you get 40 euros back for every euro you spend. and in Germany it's even greater. So it's a massive return on investment across that 10-year period it was modelled. But even if you look at the most expensive form of treatment, scenario 5, which is the the diagnosis and treatment of 90% of periodontitis, you still get a positive return on investment in pretty well every country, apart from, I guess, Italy, where there is, but it's pretty small. This is increase in healthy life years, and it probably looks to you as if there's not a great deal happening here. You've got the 5 scenarios for each country, and the very far right scenario is scenario 3, that is the eliminating gingivitis, and then the next one in from the right for each country is diagnosing and managing 90% of periodontitis. And the reason it doesn't look like there's a huge amount of change is because of your y-axis there, because that's healthy life years, and you're into 700 million. So it kind of flattens the bars. We should have plotted it on a log scale with hindsight. But what you can see is that by far that the highest gain in healthy life years comes from scenario 3 on the right and scenario 5 second from the right. So what does all this mean? How can we kind of sum this up? Well, the economic analysis showed that eliminating gingivitis or increasing the rate of diagnosis and treatment of periodontitis to 90% has a positive return on investment in all 6 of those European countries. And what was interesting was that by far the most cost-effective model over 10 years was eliminating gingivitis. And you could see that if you like, the reductions in treatment costs were as high as 36 billion euros over 10 years in Italy, and the lowest was just under 8 billion in the Netherlands, still quite significant reductions in costs. The reverse scenario is neglecting to manage gingivitis significantly increased costs and also reduced healthy life years. And so an emphasis on patient education, on self-care and prevention is far and away from a cost-effectiveness perspective the ideal approach, which is a bit ironic because, as we'll discuss later, in the current NHS system, you don't really get paid, you don't get paid or remunerated for speaking to your patients or educating them. You only get really remunerated for getting sharp metal things out and poking them in patients' mouths and intervening. So the current system doesn't encourage prevention, it encourages intervention. The Economist also did a narrative piece. They didn't model this financially on the impact of periodontitis on general health, and they came to the conclusion, independently of the FP, that integrating general and dental care was really important if we're going to improve holistic management of patients in the future. And to do that, you've got to be able to sort of share databases, share records on common risk factors, for example, and communicate between the professions. But of course, we have separate IT systems. And it's to be hoped that the introduction of SNOMED coding will help us achieve this. Because for those of you that aren't familiar with SNOMED, it is, and I'm sure everybody working in practice is very familiar with it, it's now a system that's been informed. The FP have worked with SNOMED to make sure the new classification system is fully embedded within the coding system. So instead of very old-fashioned terms that were in there, such as periodontitis gravis, for example, they've all been stripped out, and we now have the correct classification system in there. And then integration would also ensure that shared responsibility between disciplines, which is also incredibly important. So the other conclusions really related to how you conduct your public health campaigns. Do you do it at an individual level, or do you do it at a societal level? And the conclusion really was that you've got to do both, because if you do one and not the other, you'll capture that group that are probably the group you're not trying to capture. You want the ones who are not accessing care, oral health care. So you'd probably just exacerbate inequalities by not taking that two-pronged approach. Societal level prevention is critical, especially because the disease is very, very highly prevalent in these low socioeconomic areas. And then interventions to promote better periodontal health need to be embedded in community settings, such as, for example, religious groups, pharmacies, schools, anywhere that the public access that isn't in a traditional outpatient type of or inpatient type of environment. Dental care is too expensive in many countries. It's something that really struck me actually when I saw the raw data, because we grow up in an environment with educated people and we treat patients who access our services. Well, that is a biased proportion of the population. They're the ones that can afford to access our services because they're still paying out of pocket, unless you happen to be pregnant or able to, or you're on benefits and not paying. And it's actually those people with those with incomes that are just high enough to not warrant free access to care that really suffer here, and they're quite a big group. And as I mentioned, dental care may appear to be free on paper, but certainly in the UK and in countries like France, it's not. There are out-of-pocket expenses for patients. So periodontal treatment for a low-income family was deemed to be unaffordable by the Economist group, and the study also provided evidence that if you professionally manage the disease, whether it be through treating gingivitis or whether it be through treating periodontitis, it is in fact very cost effective, and therefore policymakers across Europe really need to wake up and smell the coffee and start making sure that they fund periodontal care properly. So that's the end of the first section. I leave you with two smiling daughters because it was the summer. They'll kill me if they know I showed this, because as I said to Zira, it's kind of holding slides. So I'll quickly move on. The next section, I wanted to share some data with you before I went into the new data on the classification system on a survey that I did way back in, was 20 years ago, 2002, when we had fee per item, and it was a survey looking at what the barriers were to periodontal treatment in the primary care settings. And it was done by questionnaire to NHS general practitioners and also to specialists, periodontal specialists. And the focus was on time and remuneration. And we validated it with focus groups before we did it, undertook a pilot study, then the definitive study, which was on 865 GDPs, and we undertook 3 mailings. And one aspect that it was based upon included a case study, and that's what I'm going to show you is that case study. So there it is. This is one of my patients at the time who, I suppose, at a quick glance, if we ignore the periendo lesion on the upper left 6, looks to have stage 3 disease. She was quite young at the time. I think she was about 30, so this is probably grade C by the looks of it. But anyhow, that's the case. I told them to ignore the periendo lesion on the upper left 6 and assume it wasn't there. And then the question was, oh, I'll give you the response rates first. There you go, 64% from GDPs, not brilliant, but not bad, and just under 90% response rate from the specialists. It was 59 specialists that we accessed at the same time. So the first question was, how long would you be able to spend treating this case in your practice? And you can see that the GDPs were around about 1, maximum of 2 hours, whereas the specialists were closer to 4, and in the majority of cases 5 or more hours. So they were inversely related almost perfectly. And that's of course because the specialists are charging by time, whereas the general practitioners working in the NHS were having to take the item 10C at the time payment, which I think at the time was around about £60, something like that. The next question then was slightly different. It was how many visits would be required to treat the case in your practice in an ideal world. And all of a sudden, the GDPs sort of acknowledged, well, it really is going to take longer. It should take between 4 to 5 hours. So they started to align more with the specialists, which basically tells us that the GDPs knew what they needed to do, but they just couldn't afford to do it. So they were doing the best they could in the time available, so their practices didn't go bust, frankly. And then the next question was, well, how long would you spend treating this case actual time in an ideal world? And this was the specialist. So this is what I'm doing here, is taking the last slide and then breaking it down into specialist responses of ideal versus actual, and you can see that there's a perfect match pretty much there or thereabouts. So the specialists were spending the ideal amount of time. They were actually spending the ideal amount of time, I should say. But whereas when you looked at the generalists within the NHS sector, they weren't. The ideal time that we've mapped there is a lot more than the time that they were actually being able to spend. So interestingly, we then had the 2009 UK Adult Dental Health Survey. Now, I believe from memory, the UDA system came in around about 2006. It was too soon to really impact on this data. If we look at 1998, you can see 54% there with periodontal pockets, therefore with periodontitis. The green 46% is not health, it's full of bogging gingivitis, but at least it's not periodontitis. And then when we looked at the 2009 survey, I remember getting the press release from the Department of Health, I think it was at the time. Look at this good news story. Perio's down to 45% from 54%. And I remember writing back and saying, no, this is a really bad news story because your severe disease, which takes so long to treat, has gone up from 5 to 8%. What it's showing you is that the item 10A and the item 10B, which most practices can afford to do, is working for the really mild disease, but actually the item 10C is not working, and the moderate to severe and very severe disease is not being managed. And funnily enough, the press release didn't go out. Surprise, surprise. And then when you look at the over 65-year-olds, we've got 60% prevalence there. I'm sure most of you know this data, and 14% with severe disease. So, it's relevant because we have an aging population who are retaining their teeth for longer. So the periodontists of this world and the dental hygienists are never going to be without enough work to do, not for a long time yet anyhow. So why is the prevalence of severe disease worsened? Well, if you look at the finances under the story I've just given you, the fee per item was actually £100 per case in 2002, and I reckon that at the time you could probably justify spending 45 minutes to cover your practice overheads per hour at the time. UDAs introduced in 2006, as I said, and perio falls under band 2, so you get £80 per case maximum, unless you're on a very, very high UDA value. So on average, you get less than you did under the old fee per item system. So is it surprising, in fact, that the more severe disease has increased in volume? That's not the only reason. There are other reasons, such as that last bullet point, as I've mentioned already. So when we look at treating the disease, we have to look at the population as a whole. That's what governments do. And you'll be familiar with this business pyramid. It was Jimmy used it in his report, but it's a classic business model. And when you look at the base, which is where we're treating the bulk of the population, you really have to be treating the bulk of the population cheaply and effectively, because the higher up the pyramid you go, patient factors become more complex, patients become more complex, and the clinical treatment therefore becomes more complex and therefore more expensive. So you really don't want to be undertaking the advanced care on somebody who's not engaged and who's not periodontally stable, because poor foundations to any bridge or any reconstruction are going to result in failure, and that's a huge cost to the taxpayer, to us, and to our patients. So some of you will have heard me talk about this, and you might be sitting there thinking, yeah, but that was a year ago, what the hell's happening? Well, what is happening at this moment in time is that there is a huge amount of work going on at the Office of the Chief Dental Officer, and a massive amount of work looking at contract reform. And at the moment, it's been delayed, and the latest we have is it's probably going to be delayed until April 2023. So the ideas behind contract reform are very much about trying to allow practitioners the time to spend with their patients, to have those conversations, to fund prevention rather than intervention, and therefore to model this pyramid. And in the interim, there's a need for some kind of solution to deal with what is the most awful system ever invented, the UDA system. I call it, UDA stands for unfortunate decision all round. And I remember presenting that to to NHS England in a talk I had to give this time last year, and you could see the eyebrows being raised, and that was the signal for me then to lay into how dreadful it really is, and how if they don't do anything, there'll be nobody left in NHS dentistry. It is really tough out there in practice at the moment, and I'm afraid I'm not going to get into politics, but the government are not making life easy, and certainly not making life easy for the OCDO, who just seem to hit barriers with everything they're trying to do. So what do we do in the interim? I'm going to come on to that at the end of the presentation, and then that is what Shazad will take you through in more detail in the next webinar. So just before I go into the classification bit, really just to remind you of the pathogenesis of the disease, and you'll see why in a minute, because I love this slide. It was one from Steve Offenbacher from a Scientific America article, and it's a beautiful slide which he kindly sent to me to use. And what it illustrates is that we need, even in health, a health-promoting biofilm. We're holobionts, we live with our bacteria. There are 2 bacterial cells for every 1 human cell, so we're really more bacteria than we are humans, and we have to live with those bacteria, but we need the right bacteria. And of course, the tooth, unfortunately, is a non-shedding surface, unlike skin, which sheds. And so if the biofilm's left to build up, then it can start to mature and irritate the underlying sulcular epithelium, and those cells will signal into the underlying connective tissues to generate an immune inflammatory response, and the inflammation therefore develops, and we call that gingivitis. As part of that process, we get the breakdown and the microulcers forming, as you can see there, those holes in the sulcular and the junctional epithelium. But if we disrupt the biofilm or reduce it, then we reverse that condition. But there is that group of high-risk patients who, irrespective of having reasonably good levels of plaque control, go on to develop periodontitis. And we know the reasons why in broad terms. We do not know the reasons why in granular detail, and we're some way off knowing that. But we do know that it's down to a dysregulated immune response, and 80% of the tissue damage is caused by that dysregulated immune response. And of course, the latter is driven by our genetics and also by our lifestyle, such as and factors such as smoking, hyperglycemia, etc. So when we look at the modern way we approach prevention, we've got the bugs and trying to maintain healthy bugs and prevent dysbiosis from developing. We've got this exaggerated immune response in the host, which drives the dysbiosis, but is also driven by it. It's a kind of a circular relationship, that. And then we've got the individual patient and what their desires are for treatment, the outcomes of that treatment. So those 3 really were built into the new classification, and I'm not going to bore you going through the whole thing, don't worry, but I just want to share some data with you on the ability of the system to predict tooth loss. And this is a paper that was published just a few months ago in the Journal of Perio, and it was really driven by a group in Louisville working under Henry Greenwell. And Henry Greenwell, you'll see there on the paper, you may or may not realize, was the guy that actually wrote the staging and grading with Tonetti and Papapanu at the time, and Henry was fairly critical to that process. But he's an honest scientist, and therefore he was quite keen that this data was published. And the reason for publishing the data was they wanted to look at the performance of the BSP implementation of the World Workshop classification, because they thought it would be worse at predicting tooth loss. And I'll never forget the phone call when Mohammed Saleh phoned me up. I said, why the hell do you think it's going to be worse? It's bound to be better because it's simpler and it's focused only on perio in the staging. So anyhow, they did the work, and the aim of the study was to assess over a period of more than 10 years the prognostic ability of both systems and the staging and grading aspects of those systems in predicting tooth loss over that 10-year period. And that tooth loss, TLP, is tooth loss due to periodontitis. In order to do that, they had to use a unique data set at Michigan Dental School that has been going since 1966. And these are cases that have been treated in Michigan and followed up in Michigan. So the teeth were all extracted there, and the reasons for extraction were recorded. And that's the big challenge with stage 4 periodontitis, which is why we don't have extracted teeth in ours, whereas the World Workshop system, the original system, does. So they looked at 270 patients that fulfilled the criteria of the case definitions from Maurizio Tonetti's paper at the World Workshop in 2018. And to be eligible, patients had to have had at least one session of debridement, plus or minus surgery, and they needed to have been maintained for equal to or greater than 10 years. They had to have been maintained at the University of Michigan Dental School, and they needed complete charts, full mouth radiographs that were of diagnostic quality that were taken within 12 months of baseline examination. They had to have a complete medical history at baseline, and they had to have had at least one or more sessions of supportive periodontal therapy throughout the entire follow-up period. So quite stringent criteria. And they had to have had any teeth extracted at Michigan, so the reasons were available and documented. I know there are statisticians, probably, I know one or two people with far greater stats knowledge than me, but just so you know, that's how the modelling was done. I'm not going to describe it to you. I'm sure you know Bonferroni is a correction for multiple comparisons, but the important one is what's called the Harold C index, and that is a measure of accuracy of prediction, and you need a value that is above 0.92 for an excellent predictive value. So these are the results, and in red, so you've got 3 blocks, sorry, on the top chart there. The left-hand block is stage 1, 2, 3, and 4, and what percentage of patients fell into those stages using the BSP system in red and the World Workshop system in blue. In the middle, you've got the grades, A, B, and C, and then on the right-hand side, you've got the extent, localized or generalized. And when you look at staging, the main differences were really between stage 2 and 3, where significantly more patients were categorized in the lower stage, the moderate stage rather than the severe stage in the BSP system relative to the World Workshop system. And when you looked at grading, there were significantly more people graded at grade A in the BSP system than the World Workshop system, and fewer at grade B. And then one of the biggest differences really was for localized versus generalized disease, with significantly more in the generalized category for the BSP system than for the World Workshop system. So when you look at tooth survival, Kaplan-Meier curves are used here, and what you have on the top row there is the stage, the grade, and the extent according to the World Workshop system, and then the different colors are the different stages. So if you look at the top left-hand graph, you can see stage 1, 2, 3, and 4 are the different colors. And then below, in the bottom panel, you've got the BSP system. And there's not a huge difference, to be honest, between the classification stages in the two systems, or indeed in the middle, in the grades between the two systems. Where they really separate is with the extent, where you can see the BSP system seems to assign more to the generalized category than to the localized disease category. And what the data showed was that there was an overall prognostic performance for both systems that was very similar in nature. So the overall performance, BSP was 0.925, so that's above 0.92, so excellent, and same for the World Workshop system. And when it came to staging, the BSP system was slightly better. They're very comparable in the World Workshop system. When it came to grading, it was the other way around, very slightly better on the World Workshop system for the grading versus the BSP system. And then when you look at the extent, actually the World Workshop fell short of the 0.92, but the BSP system hit it. But that's just in terms of Harold's index. It doesn't tell you about the statistical significance. And when it came to the statistical significance, then for the World Workshop system, stages 3 and 4 correlated with a poorer prognosis, but only a trend was seen for grade C. that didn't reach statistical significance, and the extent didn't correlate with a poorer prognosis at all. Whereas for the BSP system, all analysed variables, stage, grade, and extent were significantly correlated with tooth loss due to periodontitis, both in the univariate and in the multivariate analyses. So they were surprised. I don't think we were, but they were. The overall performance of the BSP and the World Workshop systems is excellent, really, when it comes to predicting tooth loss. You can use either, but I have to say this because it's a BSP webinar. BSP system's all right, guys. You can be comfortable using it in practice. So finally, I want to move on to the S3 treatment guidelines. And I just want to give you a little bit of information on how they work. It's an incredibly complex process. And I must admit, I think those of us in the organising committee there on the right have lost many hours and evenings since Christmas trying to get the final guideline paper written. And I'm going to be moving on to it again later tonight because it's got to be in by tomorrow. You will notice an incredibly male-dominated organising committee. At least that's what it looks like on the surface. But you'll notice there is one female in a black dress, and actually she is the boss. That's Dr. Ina Kopp, who is a surgeon, a general surgeon. She's German, and she is brilliant and absolutely rules that group with a rod of iron. You know, when she tells people to shut up, they shut up and listen. So she is the methodological expert that keeps us all on track and is completely unbiased with all aspects of what she does. Interestingly, she smokes like a chimney and drinks large glasses of red wine. So she's also great company at the dinners after these workshops. Probably shouldn't have said that, but she won't mind. So this is how it works. A lot of people say, well, what is an S3 level? It's quite simple. S1 is the lowest level of recommendation. S3 is the highest. And S1 is where you get a bunch of experts that sit around a bar table or in a restaurant or at home, and they have a chat and decide what they believe the right way to treat a particular condition is. So it's a kind of an expert consensus that they reach that has no real evidence base other than their own experience and gut feeling, which does have value on its own. The S2 level is a higher level, and there are two types. There's S2C, which is basically the same as S1. The difference is you broaden your stakeholder group. So you bring in people from other disciplines other than perio, you bring in people from public health, you bring in patients and members of the public. So you've got a very broad representation. The S2E level is different. That is entirely evidence-based. So you undertake systematic reviews of the different treatment proposals, and you then base your recommendations only on the science. And then the S3 does both. It brings them together. So you essentially have the systematic reviews that are undertaken to provide the evidence base. Then you have your representative guideline group, and therefore those two work in conjunction. And I'll explain how they work in conjunction in the slide after this one. The evidence from the systematic reviews is graded using what's called the grade approach, whereby the quality is assessed. Obviously, the highest quality, number one there, would be a large number of randomized controlled trials addressing a particular issue, and the lowest level would be either expert opinion or case reports. So how do you get from your evidence to your recommendation? What does that framework look like? Well, if we start off with the quality of the evidence and then look at the strength of the recommendation, if you have high quality evidence, lots of systematic review, lots of RCTs within the systematic review, then you end up with a strong recommendation. And the term we recommend or we recommend not to use a particular treatment is used. And you have to use that word, recommend or not recommend. And that's a strong recommendation. If the quality of the evidence is moderate, then you use the term we suggest you do or we suggest you don't, depending if it's a positive or negative recommendation. And if the evidence is low or very low, then it's an uncertain recommendation. So you either make a clear statement that says, well, actually, we don't know, or you can say, treatment A can be considered. And then we have to take into account a whole host of other factors that are actually quite relevant and quite important. So things such as ethical and legal issues, things such as benefit of balance versus harm, the cost of a particular treatment, or the impact on the environment, systemic antibiotics, for example. We know that you get better treatment outcomes for treating periodontitis, but actually, if you look at the impact on the environment and antimicrobial stewardship, you can't really justify it. So that's where the discussion from the consensus group comes in, and then the evidence is either modified down or up to that final recommendation. So the final recommendation is a hybrid of the quality of the evidence and then the consensus on these other factors. So that's really how it's done. And you end up with this is just one table I'm going to show you that this was a systematic review done by Luigi Nibali and colleagues, and it was based on 22 randomized controlled trials. So clearly high quality evidence from that systematic review. And so the strength of the recommendation is a grade A. So the terminology that's used is we recommend, in this case, double up arrows. And then you'll note at the bottom, the level of consensus is recorded. So for this one, there was only just a consensus. It wasn't a strong one, and it wasn't unanimous. And 10% of the group abstained because of potential conflicts of interest. So you have to document any conflicts of interest before you vote in these systems, and they are documented. And even if you give a lecture for, a particular oral health company, then you have to declare that, and you can't vote on something that might be relevant to their products. So obviously unanimous is 100%, strong consensus over 95%, consensus between 75 and 95, simple majority 50 to 74, and no consensus is less than 50%. And then what we did was take all of those recommendations and built them into steps of care, and there are 4 steps of care. I tend to talk about this staircase. I use price as a mnemonic, if you like, because there's a price to pay for getting this wrong. And the P actually is step 0. This is what should be happening in the background. We should have public health campaigns educating patients. They're going to be diagnosed and risk assessed, and a care plan or a treatment plan put in place. Step 1, as you know, is about controlling risk factors. It's about educating the patient, giving the oral hygiene instruction, and PMPR, supragingival PMPR, and any adjuncts, and in particular mouth rinses that you may wish to build in as adjuncts to that mechanical debridement, which is the most important aspect. Step 2, the I in step 2 stands for intervene, and that's really your RSD, your subgingival biofilm and calculus removal. C is step 3, that's the check or the review 3 months later to identify non-responder sites. That's when the detailed pocket chart is essential. And then you would retreat. You may do surgery in some situations, but probably repeat the non-surgical work first. And then finally, step 4 is I use E for exit. It's the exit plan. Do they move into supportive care? Do they need any teeth taken out? And do they need rehabilitating? Which is the next S3 guideline that will be published in a few months' time. So the final thing to say really is, having taken that guideline at a European level, it's important to go through what's called an adoptment process, which is a posh term to say you need to look at it in your own country and either adopt the recommendations 100%, or you can adapt them slightly to suit your own healthcare funding system. And that's what the BSP did. And you, I'm sure, be familiar with the paper published in Journal of Dentistry that came out of that. Now, the BSP has produced this flowchart, which is available from the BSP site. There was a slight glitch with that QR code, but I think it's working now. It takes you to a video. And basically, I'm not going to go through this now. Shazad's going to go through this in a lot more detail, but it takes you through for the periodontitis patient, it takes you through step 1, the re-evaluation, and then through step 2, 3, and 4 for the engaging patient. And it's only the engaging patient that you would move into step 2. And at the bottom there is the definition of engaging versus non-engaging patients, which again we'll come on to in a bit more detail later and with Shazad's presentation. I'm sure many people will have seen this. It's something I did many years ago, and Shazad and I are quite keen on this type of approach because it builds risk assessment in at the patient level when you first see them, and then at the mouth level, once you've examined them, you've got more knowledge of what's going on in their mouths. And then at the tooth level, once you've treated them, because you know what's happening at a tooth level, and then when you do your detailed charts, you get site level data. And so you can address the different risk factors at the different stages of treatment. Now on the y-axis there, you've got the amount of disease, the number of disease sites when the patient first presents. And then in step 1 of care, you've got 2 kind of subcategories. You've got the education phase, which is also involving the oral hygiene phase. And you get a huge reduction in pocket depths with that alone if the patient engages with what you've trained them to do and coached them to do. Then the second part of step 1 is the PMPR, scaling of the crowns of the teeth, and essentially you get further improvements there and correcting plaque retention factors. Then in step 2, you've got the subgingival debridement, again, further significant improvement. And then in step 3, you've got your retreatment, perhaps some surgery to get them to a point of close to 100% closed pockets. You sometimes get there, but most of the time you don't, and you have a few residual sites. And that's the point at which you would move people into the maintenance and supportive care phase. Now, what's interesting is the red arrow at the bottom on the x-axis shows you the cost increases as you move from the left to the right. And the irony is that the effectiveness decreases as the cost increases. By far the most cost-effective stage is step 1 of treatment. And I'll come back to that just at the end. So I put these pretty circles in for some reason, and I think I probably just forgot to click my mouse when I did, but it just reinforces what I just said, hopefully. When we look at step 1 of care, Shazad and I share slides, so he sent me this the other night. He summarised into step 1, 2, and 3 what the major issues are. So I've nicked this from him and just adapted it slightly. And in step 1, the first step in treatment really is focused on that behaviour change and that motivation and the successful removal of deposits and controlling risk factors. And it's likely to involve supragingival biofilm control, the OHI and the motivation and the education in the reverse order, I should say, educate, motivate, and then do the OH. Adjunctive therapies for gingival inflammation, PMPR, and risk factor control. So that is essentially step 1 of treatment. And that needs to be implemented for every patient, irrespective of the stage or grade of disease they've got. And then it needs to be reevaluated a period of time afterwards. And you need to really continue to build that motivation. Positive reinforcement of messaging is really important in order for patients to remain motivated and keep that going for the rest of their lives. You need to develop the patient's skills in biofilm removal and modify on a regular basis, and then allow allow time for an appropriate response to treatment. So this is all about patient engagement and establishing patient engagement and getting the patient to take ownership of their oral hygiene. And if they do that, then they would progress to step 2 of care. And how you implement your behaviour change is, it varies. There are many different ways of doing this. I always tell the same story about one of my patients, so apologies if you heard this before, but it's just one example of many different approaches you can take. And this patient was a neurosurgeon who was referred back in 2007, and he didn't turn up for his first appointment, so I discharged him. as we do routinely in the hospital in such situations. You can see the amount of disease he's got. Most of these teeth look terminal. Because he's a neurosurgeon, he has a PA. I have a secretary, so his PA phoned my secretary and gave her a bit of an ear bending over discharging him because he's a busy man and he was stuck in the operating theatre and he couldn't come to the appointment. And would we send him another one? So we did send him another appointment, and he turned up 20 minutes late. So I refused to see him because I had another patient in the chair. And like a true coward, sent my nurse out into the waiting room to break the bad news, which she did. He stormed off, and then his PA was back on the phone, ranting and raving and threatening and menacing. And would we give him another opportunity? So we did, on the basis that he needed to turn up on time, and he did. And unfortunately, I was running 40 minutes late. So when he came into the room, he was not best pleased, and he sat in the chair and basically degranulated. He just let rip for a good 2 minutes about how busy he was, how insulted he was by my attitude, and how rude I'd been. He was in the operating theatre 16 hours a day, patients basilar artery in his forceps, one slip and they're dead. What did I expect? And I listened to him, and eventually, when he finished, I sort of looked at him and didn't say anything for a good 10 seconds, which is a long time. And he started to look a little bit nervous. I think he thought I'd had some kind of a stroke. And I said to him, look, it's very straightforward. I appreciate your frustration, but if you want treatment, you've requested treatment of me, and if you don't turn up, I can't treat you. And if you're 20 minutes late, I still can't treat you because I've got somebody else in the chair, and they're equally as important as you are, I'm afraid. And then the third point I made was, because I'd just actually done an appraisal, my own appraisal, where the medical director had asked me about my health, which is actually the right thing to do. And I said to him, if ever I develop a glioblastoma, you are the last neurosurgeon on this planet that I'm going to come to see for treatment, because you're not fit to be practicing. You're operating too long. You shouldn't be in the theatre that long. You should have a staged approach to your operating with teams. You really are not looking after your own health. You're not making the time in your own life to sort your own health out. And therefore, if I was doing your appraisal, I'd be writing to the General Medical Council to say that you were unsafe to be practicing. And at that point, he did an impression of a goldfish and shut up and let me get on with the examination. And this is him after 3 months of non-surgical treatment. He became one of my best motivated patients. With the exception of a root amputation and a temporary sort of natural bridge on that upper left tooth, the bone has regenerated around those apically involved lower incisors. We've got an endo to do on the upper left one, which was done. And then 10 years later, this is him in 2017, he's lost no more teeth. We've done orthodontics on him to close the gaps. And I always say jokingly, but it's true, it's really easy with people with stage 4 periodontitis because there's no bone left and the teeth move really quickly. So didn't take long, put him in fixed retention, job done. I asked him how long he spent on his plaque control regime, and he said, well, actually, I spend 20 minutes in the morning and 15 minutes in the evening when I get back from work. And he said, and you'll be pleased to know I don't operate any longer than 9 hours now. So this guy completely changed his lifestyle, which must be very, very difficult. And people say to me, well, what was the behavior change technique there? And I don't know, but I think it was probably challenging his professionalism, because he's obviously a brilliant surgeon, obviously very proud and very caring, putting those hours in, but actually it was a wake-up call because the hours were too long and he wasn't looking after himself. And now he does. I just wonder how many of us could do that. I'm not sure I could. So hats off to him. So terminology, you will be familiar with the fact that we now use PMPR, professional mechanical plaque removal, and many people say, oh, that's just a fancy word, isn't it? Well, yes, actually it is. But the main reason was to get rid of the term scale and polish, which is an abhorrent term. And there are several studies that have shown it's completely ineffective at achieving anything, because what the scale and polish is about is getting stain off teeth and beautifying the patient. And patients want you to do that every 3 months. Well, you know, I don't know about you, but I'm not interested in that. I'm interested in treating disease and preventing disease. And that involves actually doing proper, serious treatment to improve outcomes for patients. And so PMPR is a European term. What it really means is scaling of the crowns of the teeth and of restorations. It refers to prophylaxis or polishing, if you want to call it that, and that would also include air polishing. When it comes to subgingival PMPR, it's fine to call it root surface debridement. That's a term we in the UK have used for many years, thanks to Bernie Kieser and many of his colleagues, and we still use it. So subgingival PMPR is basically refers to scaling of the roots of the teeth, or subgingival scaling, or subgingival debridement, or root surface debridement, or subgingival instrumentation, or root surface instrumentation, all the same stuff. The key thing is that these days we use lighter forces and we're not as aggressive as we used to be. So the term root planing is kind of old-fashioned and out of date now, as is the term curettage, unless you have an abscess, in which case you need to curette the pocket lining in order to drain that abscess. But that's the only situation that we would actually undertake curettage. And it's the death of the scale and polish, and that's been signed off by NHS England and is now a banned term in Birmingham and many other places, thank goodness. Okay, so if we move on to step 2, I'm not going to go through all the tables, just really to point out that this is what is also called cause-related therapy, and it really aims to control the subgingival biofilm by removing calculus and endotoxin as well. And so that might include the use, in addition, of adjunctive physical or chemical agents. It may include the use of adjunctive host modulating drugs or agents, the use of the adjunctive use of subgingival locally delivered antimicrobials or systemic antimicrobials in specific cases. And the only cases that can be justified in are young patients with grade C disease who have relatively good plaque control. In other words, the rate of progression of disease is not consistent or out of step with the levels of plaque control and local risk factors. I'm fairly sure you know all that. Step 3 of care involves really the detailed chart to identify non-responding sites and then to re-instrument those non-responding sites. The aim of treatment is the closed pocket, which is 4 millimeters or below and no 4 millimeter bleeding sites. And deep pockets in the literature, believe it or not, are defined as 6 millimeters or greater. I think for most periodontists or hygienists, we wouldn't regard that as deep, but that's how it is defined in most of the literature, and that's what we've stuck to in the treatment guidelines. You may, at that point, need to undertake surgery. Generally in the UK, we would undertake a second round of RSD on the non-responding sites because you can spend more time on them and you can look at those, you can do that site-specific risk assessment I mentioned in the graph. And you know, if you do surgery, then it may be access flap, resective or regenerative in nature. And then finally, step 4, which is really following the active phase of treatment when the patient is stable, you would move them into step 4. And you may have 2 subcategories really. You may have the periodontitis patient who has got a reduced periodontium, but it's healthy, all 4 millimeter or below sites and no 4 millimeter bleeding sites, they would be stable. Or you may actually have a periodontitis patient who has more than 10% or more bleeding sites in their mouth, and they would be said to be in remission. And the reason we use that is that clearly with increased bleeding, gingival bleeding, even though the pockets haven't started to deepen again, they're probably about to. And so that should be ringing alarm bells that you really need to focus down on getting that biofilm back down to the levels it was at when the patient became stable. So there may be some residual sites that need monitoring. You're not going to get 100% closed pockets in the majority of cases, and there's no guidance for this other than one paper published just over a year ago by Magda Ferraz and colleagues, which basically looked at a data set from Brazil and came out with a pragmatic endpoint of it's okay to have some 5mm or deeper sites, provided it's equal to or less than 4. That will be deemed consistent with a decent treatment outcome. And what you would do with those residual 3 or 4 sites is monitor them closely, maybe go back in and retreat them at those supportive care visits if needed, in order to try and maintain them. And supportive care in step 4 really is about maintenance. It's about remotivating the patient using exactly the same techniques as step 1 and 2. And you would perform it at regular intervals. And we normally say start off at 3 months and do it every 3 months. But if you find that you're getting nothing that needs retreatment and that everything's beautifully stable at 3 months, you can titrate it back to 4 and then to 6. And I've got some patients on 12-month recall. They're still high-risk patients, but they're so good at doing it that I never really need to do anything other than the detailed chart and reassure them. And really, adherence and engagement is critical to that supportive care phase. So your therapeutic options in simple terms are non-surgical, resective surgery, regenerative surgery, or potentially in a stable patient who's demonstrated good plaque control, extraction and implant placement if necessary. So just a little bit more to go. So to summarize that section, the sort of international classification system that we've developed really has been based on that sort of biological evidence base, but it also does embrace risk assessment. The S3 international guidelines for stages 1 to 3, but in the BSP system, that's all forms of periodontitis, stages 1 to 4, has essentially now been developed to map onto that classification system. The treatment guidelines are in those 4 steps, as we've outlined, and national societies have now all pretty well adopted those guidelines to suit their own systems. So just for the last 5 minutes, how can we make this work without contract reform? So going back to what I said at the beginning, how can we really improve the situation in NHS practice and provide more time for those patients that are putting the effort in and really deserve the time? And for me, I felt this was a massive success for the BSP in the last sort of 6 months, because it took a lot of work to persuade NHS England and the BSE to go with this. But what they've agreed to do is, instead of 1 band 2 payments per year for periodontal treatment, there are now essentially 4 payments for a course of treatment. 3 are going to be within the 12-month period. And this is the document. If you've not seen it, this has gone through Government Gateway, so it is now official. And you will get paid to do this, provided you follow it. And this is what Shazad's going to take you through in more detail at the next webinar. But in simple summary terms, you can open a course of treatment, a band 2 course of treatment for step 1 of periodontal care. 3 months later, you would review the patient, and you can open a second course of treatment for step 2 of care, and that's another band 2 treatment. And then following that, 3 months later, for step 3, again, another band 2 course of treatment can be opened before the patient then moves, hopefully, into periodontal maintenance or into referral if necessary. And so this is now absolutely legitimate. To be honest, Healthy Gums Do Matter have been using this type of approach because it was always kind of legal, but it's nice to have it actually fleshed out and authorized. And you can see the 3 courses of treatment within 12 months there, and then your 4th band 2 payment would come for step 4, because you've got to do your detailed chart and remotivate, and it all takes time. So going back to my original graph, what it's done is it's kind of moved things to the left. It's providing remuneration for that step 1 of care. Step 2 is expensive and not cost effective for that 1 band 2 payment, but actually you do get step 3 and step 4 if you get step 1 done and completed and the patient is an engaging patient. And that's the critical thing. You cannot move your patient from step 1 to 2 unless they demonstrate engagement. and I'll just finish off by showing you the flowchart that's been done by the BSP. So I mean, it's interesting, we had this discussion last night. I was asked last night, what are you guys in the UK calling the classification system, the 2018 or the 2017? I said, well, we're calling it the 2017 system because that's when we did it. It would appear that most other countries are calling it the 2018 system because that's when it was published. So we now call it the 2017 workshop classification system, but it's the 2018 classification. I just thought I'd slip that one in because that's now an agreed approach. Anyhow, so step one, first course of treatment, band 2 payment. Probably wise to give your patient a ring and do a bit of remote consultation after a couple of months to make sure that they're keeping the plaque control up, even if it's really brief, just to keep them remotivated, because when they come back at 3 months, you want them to be engaging. Because if they're engaging, you can then move on to step 2. If they're not, you would then undertake a second course of treatment, which, you know, Shazad and I both believe, we agreed with the BSA, you would get a second band 2 payment, but we just need to clarify that with them in order to try and get that patient to engage. If they don't, then they move into palliative periodontal care and they go on the essentially the band 1 payment system. If they do engage, then you move into step 2 and do your RSD. 3 months later, you move into step 3, rechart, re-instrument if necessary, and then you move into step 4 once you've looked at your outcome measures, which hopefully will involve periodontal supportive care within your own practice. And if not, then you would need to refer, and if you've got pockets of 6 millimeters or more, refer to level 2 or 3 care. So engagement is defined in green at the bottom there as a 50% improvement in plaque and marginal bleeding scores, or getting levels down to less than 20% plaque levels and less than 30% bleeding levels. Slightly more than the literature, recognizing this is being done in primary care practice, but closer to healthy gums do matter, not identical, but not far off. And obviously the non-engaging patient is, if you like, the mirror of that. So I'm putting this up just to make you all throw your arms up in horror and say, oh my God, what's this? Well, this is my last slide, and I don't want you to read it. I just want to point out that this is available, you know, on the BSP website, and just get yourself a glass of wine sometime and just sit down, have a look at it for 5 minutes, because what it does is it takes you through a patient who may have stage 1, or you might want to look at a stage 3 periodontitis patient. And you can take each scenario, whether it's localized or generalized, and it will take you through, in green for the engaging patient, the steps of care that you would be expected to go through, and in red at the bottom there for the non-engaging patient, you're probably going to be referring them at the end of those 2 step 1s that you've undertaken. So with that, I'm going to stop because that's 1 hour and 10 or 1 hour and 15. So we've got about 15 minutes for questions. And thank you all for staying with me and listening. And I'll try and come out of this and access the questions.
Thank you very much, Prof. That was a really engaging and interesting talk. We're currently just waiting for some questions to come through. So if anyone has any burning questions, please do type them into the question box on the GoToWebinar control panel.
While we're waiting, Zira, I'm just going to unplug so I can get my mouse working and bring up the question panel. So just bear with me a second.
Wonderful. Okay. While you're trying to get your mouse going, Prof, we have had a question come through. And the first question that's come through is, how long would you expect a full perio assessment to take? Hi there, Prof. Did you hear the question that came through? I think we're just having a few technical difficulties. I'm not sure that Prof. Chapple can hear us. If you bear with us, it looks like he's trying to correct his sound output as we speak. Hi there, Prof. Can you hear us now? It looks like Prof. Chapple, we can see.
Can you hear me now, Zira?
There we go. Yeah, we can hear you. Brilliant. We can see your screen still as well, by the way, so we can just see that that up there. Did you hear the first question that I posed, Prof? That's coming through from the audience, or would you like me to repeat that question for you? Can you still hear us, Prof? Okay, Prof, the first question was, how long would you expect a full periodontal assessment to take? Okay, it looks like we're having some technical difficulties. So what I can do is I can collate the questions and ask Professor Chapple to respond to these once we have him back online. And we can put the responses up at the end of the webinar to be viewed online once this recording goes live in about 24 to 48 hours time. Oh, no, you're back, Prof. We can hear you.
I seem to be working, but I can't hear Zira. Are you back?
I can hear you, Prof. Can you hear me?
Good, I can hear you. Right, okay.
Brilliant. We're back. Okay,
Let's
so
test the questions if we can.
The first question, how long would you expect a full periodontal assessment to take?
Oh, it depends how experienced you are. You know, if you ask Shazad how long it takes him, he'll do a full pocket chart in about 5 or 10 minutes, and so will I. I think when you start off doing full periodontal assessments, it could take you a good 15 minutes. I would generally bash one out in 5 minutes, and the reason for that is I don't record pockets that are less than 3 millimeters. I just put a dot in the box, or my nurse does. So I'm only really shouting out anything of 3 millimeters or above. And you can get through a detailed chart in under 5 minutes if you do that. Now, obviously, you've then got to do your plaque and your bleeding scores, and that can take a bit more time. But I think if you look at a band 2 payment, the idea is to give yourself at least 30 to 40 minutes to do that. I think that's the thinking behind it. The trouble is, I work in a hospital environment now, and that's probably a question that would be good to have Shazad answer next week, because he does it in NHS practice.
Thanks, Prof. We've also got a few questions that are related to do with the Scottish system that I'm going to ask you. So I'll combine these questions together. The first is, how would you do this within the Scottish system? The second asks if there's a chart available for Scotland NHS. And the third asks, does the BSP intend to consider the application of the S3 guidelines to the Scottish payment system?
That's a really good question. The trouble is we have no control over the Scottish system, and you know, whoever's asked the question is absolutely right. That is something that we've achieved in NHS England, but not in Scotland. Scotland is still on the fee per item system, which is better than the UDA system, but it's clearly nowhere near as good as this BSA system. So it's really difficult because BSP can support the Scottish practitioners in lobbying, if you like, for change, but we're not in a position to make the changes. I think if you can get traction from the NHS in Scotland and the equivalent of the BSA, then I'm sure the BSP would be very, very keen to support and work on systems to support the context of that environment, if you like, providing care within that environment.
We have also just had a question come through asking, Prof, with the emphasis on behaviour change, should we be educating our students, dentists, hygienists and therapists more on communication and behaviour change and motivation, such as improving lifestyle, diet and other risk factors?
Yeah, we should. And, it's quite interesting that the change in approach from hygienists working in general practice to hygiene therapists working in general practice. When we had the 2-year diploma in dental hygiene, they had really excellent training in behaviour change, and traditionally trained hygienists are fantastic communicators, and they're incredibly effective at getting the message across. With the advent of therapy, obviously there's a lot more to learn, and there's obviously quite a desire to be doing the interventive stuff as well. And we've noticed that there's been a degree of de-skilling at undergraduate level. I'm being brutally honest about this. So I think within the practice setting, there are certainly courses I would be sending hygienists on. I would also be sending my dental nurse on some of the courses and getting them trained up as an oral health educator, because dental nurses can be incredibly effective at getting those messages across. And if you use the full team, it becomes a hell of a lot more cost effective. Dental nurses aren't as expensive as hygienists, who aren't as effective as dentists, and yet they can still undertake these roles very, very effectively. So yes, I would be investing. And it's interesting, if you look at people working in the Southeast, for example, they are using the full skill mix in their practices. And you say to them, well, how's it working? Because a lot of dentists are not keen to do that because they think they're not going to have enough work. And they just described the pyramid that I showed you. They said, well, all the basic work is done by the team, and then I get to do the more advanced care because the patients are motivated and want it, and I can justify it. You can't justify doing it unless the patient's motivated and engaging.
That's a very valid point. Thank you there, Prof. We have one final question, if I may. The questions come in. Fascinating data, Iain. What trends would you predict economic intelligence data would show for stage 3 and 4 disease?
Gosh. The cost of providing care is going to go up because it's going to take more time. But I guess equally your tooth retention is going to increase, quality of life is going to increase, time off work is going to reduce. Whether that balances out at a positive return on investment or not, I just don't know. This modelling is incredibly complicated. And if we had another £100,000, we would get the EIU to have a look at it. But it's an incredibly time-consuming process to go through. And hand on heart, I couldn't say how that was going to pan out. I think one would assume that the most important thing is it's improving quality of life, it's improving healthy life years, it's reducing tooth loss. So we should be doing it, end of, and just trying to keep the costs sensible. It also depends who's doing the treatment. If the treatment's being done by, a highly trained, expensive specialist, it's going to cost a hell of a lot more than if it's being done by, a hygienist in the NHS, or a hygienist or a dental surgeon in the NHS.
Thank you so much, Prof. Chapple. That's really insightful and great to hear your thoughts on that. So without further ado, I am going to thank you for giving such an engaging talk. I'm going to thank the audience for joining us for almost an hour and a half this evening, and I'm going to draw things to a close. So thank you very much, Prof. Chapple.
Thank you, Zira. Thanks everybody for coming along.